to be sure that you are not perforating these teeth easily, because central incisors are very, very narrow. Being this tooth saver file is very, very good at removing GP. And now I'm using this hooked DG endodontic probe here just to remove the vast majority of the gutta-percha. And you can see that I've placed the lingual to length and I've placed the buccal, but it won't quite go to length. So if I push up the lingual with the pair of tweezers here, you can see now that the buccal goes to length. So that's another strong indication that the two canals join. So hello, welcome to this week's Friday clinical case, and we've got another behemoth of a case today. And this is a root canal, or root canals, of 3 lower anterior teeth. And I suppose there is an argument to say that the patient needs 3 lower incisors doing, and we could book him in for 1 appointment and do 1 lower incisor, and we book him in for another appointment, do another lower incisor. But in this case, I felt like it was in the patient's best interest that we did all 3 together. Now, the issue with doing all 3 together is, of course, you're just taking a lot on, aren't you? Especially if, say, you're newly qualified or you're not very confident with root canal. You could also argue that these lower incisors are assumed to have 1 canal each. Now, it transpires later on they don't, but it's maybe equivalent to doing an upper molar, say, a 6 with 3 or even 4 canals. So in this case, I've decided to do all 3 at the same time, and because of the extent of the lesions in these teeth, where they've been done over 2 appointments. But before we get into the case, what I do want to say is that when we look at the metrics of the channel, we can see that over 50% of the people who watch these videos on YouTube are non-subscribers. So if I could just ask you to do one thing, it's simple, it's quick, and it's really, really easy, and it's free, and that's just to hit the subscribe button. Now, if you hit the subscribe button, I promise each week, each video is going to get better and better and better. And also, if you want to bring support to the channel even further, we've got a membership program. The membership program has early access to content. So we usually run 3, 4, or even 5 weeks ahead. So if you want to get these videos early, you can watch those, and it's also got exclusive content. And we've got an amazing endodontic access video on there. It's an hour long, and it just shows you how to essentially access a root canal tooth successfully. So we'll get on with the case. I'll show you the periapical radiograph here. Essentially, this was an internal referral from a dentist that I know really, really well, know for a very long time. And this patient had traumatized these teeth about 14 years ago. Now, we know that one of the central incisors has become necrotic quite early on, and this tooth was root canaled. But what had been picked up during the recent checkup with the referring dentist is that the 2 other teeth have become necrotic also, or irreversibly inflamed. Now, what I would say with cases like this is you've just got to be super, super hot with your special tests, and just make sure that you that teeth that you are doing a root canal on actually do need a root canal. Now, in this case, if we kind of annotate here, the apical lesions, there's kind of 3 distinct bubbles here, or 3 distinct kind of areas. But what you do notice on some occasions, because the lower anteriors fit quite close together, is that you might get quite a large apical lesion on one tooth, and it might encompass the apices of another tooth, and then you might assume that tooth is also necrotic. But if you were to do, say, a electronic pulp test or do some of these special tests, it would transpire that this tooth is actually still vital. So you want to be really, really careful with your diagnosis in this case. But with this particular patient, we did all the special tests and found that all of these 3 teeth needed attention. So the patient's been consented and is happy to go ahead. So when we move over to the video here, we can see that I am ready to start my rubber dam technique. And in this case, I'm using a multi-isolation technique. So I'm going to punch holes in rubber dam 4-4, and I'm going to use 2 premolar clamps here on each of the premolars, just to make sure the rubber dam stays in place. Now, you could, with this amount of teeth, doing multi-isolation, just do it without clamps, but I feel like the clamps move the rubber dam out of the way lingually, so when you're using your liquids and stuff, it sort of pools in a nice area rather than sort of moving around. And you'll notice here that there's still gaps lingually with this rubber dam. So what's really, really important, especially when you're doing 3 teeth and using lots of irrigant, is just to seal this off. And I'm using this light cured liquidam here. Now, you can use caulking agent, but to be honest, I just feel like the caulking agent is a bit messy, and this has got like a command set. So I'm really, really happy with this kind of liquidam. And then ready to access the teeth, I'm going to go for the lower right one first. This one's got the existing root canal in it. And, you just need to be sure that you are not perforating these teeth easily, because central incisors are very, very narrow. And as we can see here, when we access this lower right one, we can see the sort of orange colour of the obturation. And I'm also going to access the lower left one and the lower left two, because really I'm going to be starting on the lower right one to try and remove the obturation material, but I want to get irrigant or bleach in the lower left one and lower left two as much as possible to make sure any bacteria, we're going to get on with the disinfection protocol, essentially, those teeth. So I know that the working length of the lower right one, this is the one that's been obturated, is 22, because obviously this is an internal referral, and I'm using this Tooth Saver 2007 rotary file at quite high speed. And this Tooth Saver file is very, very good at removing GP, but I am measuring this 2007 file about 1 millimeter away from the known working length, because what I am concerned about is pushing obturation material out of the end of this tooth. And obviously, if we push obturation material out the end, it's not the end of the world, but there is a suggestion that this would lower the prognosis. So once I've removed most of the GP and I've created like this path for my hand file to get down the canal, I'm going to try and get a working length, because I know that this 2007's actually quite reached very, very quickly down to 21 millimeters. But when we hook this size 10K file up to the apex locator, it demonstrates here that we're not actually at 0. What I'm going to do is I'm going to pick up a headstrong file. The great thing about these headstrong files, of course, is they screw really nicely into GP. So I'm going to get a size 20 headstrong file, and I'm going to screw this down just to see. And I feel like I'm getting a bit of traction here, like I'm screwing into GP. Be careful with these, they're very, very easy to separate because of the way they're made, they're spirals. And then I've noticed this H file is extending past the point to which I had with the size 10K file. And when we hook it up, I can see here that now we are past 0. So this is great, we're past the 0 reading. We're going to back this headstrong file up by unscrewing it. We're going to get the 0 reading on the apex locator. And when we pull it out, this is our working length, and it's found to be 21 millimeters. So this is really, really important when we need to be measuring, because we don't want to be relying on previous measurements, because you can see here this demonstrates that this is 21 rather than 22. We're now ready for the working length in the lower left one. This is pretty straightforward. Again, we're just going to be using a size 10K file, going to push it out the end. We're going to back it up so we get to 0. That's our 0 reading, and the lower left one is found to be 22 millimeters. We're then ready to do our working length in the lower left too, but what I do notice straight away is that the hand file is actually not quite long enough. So when I hook this size 10K file up to the apex locator, we're almost nearly up to the handle in this case, and the apex locator suggests that we're quite far away. So I'm going to use these 21 millimeter length hand files. You can see the difference here in the sizes compared to the 25, and then this gives us a bit more shank, gives me a bit more length here, so I can hook the apex locator up, and we can see here that when we have a little fiddle around, we pass 0, we back it back up, and when we pull this out, it's shown to be the working length. This lower left 2 is 25 millimeters. Now we could use the 25 millimeter hand files. The problem with this, of course, is that you haven't got a lot of space with your hand file to hook up the apex locator or to adjust the stopper in any way. And when you are really close to the right up to the hilt on hand files, it's difficult for vision to see if you are at the correct working length. So this is why we use these extra long hand files. I'm now ready to trying to remove some of the GP from the lower right one, and I'm going to use a glide path file up to 20 millimeters. This is -1 millimeters away from the correct working length, but of course I need to irrigate. Always make sure the teeth are always completely irrigated, and this glide path file shapes to length quite nicely. So what I do is I get a hand file just to check recapitulation, just to check the working length again, of course. And then I'm going to use a glide path file to 0 now. I feel like this has gone quite nicely to length. Again, I'm worried about this extrusion using rotary files with canals that I've got GP in them all the way to length. There is a risk of that, of course. And now I'm going to do my 2007 file to 0. Again, worried about extrusion, but I just want to remove the GP as quickly as possible. I feel like this is going to length nicely, so I'm not putting any added stresses onto the file itself. I'm ready to do some more shaping in the lower left one, and I'm doing this mainly because I want to get the irrigant down into all of the canals as quickly as possible, really, because I just want the irrigant to start to kill off all the bacteria, and we know that bacteria is the only reason for root canal failure. And then I'm ready to do my final shape in the lower left 2. We know the lower left 2 is 25 millimeters. The glide path file is 25 millimeters whole length. I'm not really happy about using the glide path file up to the hilt all the way to the end, but in a way, the file is open, it's ready, I'm happy, it's going to length quite nicely. So just for cost effectiveness, I'm just going to be using the rotary file in this case. And again, I'm using the 2007 tooth saver file just to give this lower left 2 an extra shape. There's a slight problem here, is that when you're using stuff right up to the hilt and it fractures, it's arguably hard to remove. But once we've finally shaped the lower left 2, I'm now ready to do my master apical file in all of the other canals, and in this case I'm going to use a Wave 1 Gold 35. And the reason why I'm using a size 35 Wave 1 Gold extra length file, in this case is a 31 length, is that the working length is 25 millimeters. But when we're doing our final shaping protocol, we need to minus 0.5 millimeters away from the 0 reading. And the issue with using, say, a reciprocation file like Wave 1 Gold at 24.5 millimeters is that the rubber stopper is too big. And I suppose you could argue that you could just shape it and leave maybe 0.5 millimeter from the shank to the incisal edge, which is the reproducible point, but it's not very accurate at all, and also it just takes you a little bit of a slip. So we're using the extra long reciprocation files here because I can set the stopper at the correct working length, and when we set the stopper to the correct working length, it's more accurate and we're less likely to destroy the apical constriction. And the same goes for the lower left one. I know that the GP has not been completely removed from the lower right one, so I'm just going to use this highest diameter reciprocation file now in the lower right one, just to see if this removes the vast majority of the GP. And here I'm just using lots of irrigant, maybe, and some ultrasonic activation as well. And I feel like, if I'm using the ultrasonic activation in the lower right one, I might as well just use the ultrasonic activation in all the other teeth, just to make sure you activate all the irrigants. Again, it's always about trying to kill the bacteria. But when we check, we can see that in the lower right one, there's a significant amount of GP left. And I'd use some ultrasonics here just to try and dislodge some of the GP. Sometimes this works, but sometimes it also can destroy the GP and make it break into little pieces. Again, I'm getting a little desperate here, and I'm going to use a H file to try and move the GP. And at this point, I'm thinking to myself, maybe there might be a bit of a double canal in this tooth, mainly because I'm using these high diameter files, and it's still not removing the GP or making any difference at all. So I'm just going to use the reciprocation files and the rotary files in this suspected lingual canal, and we can see that there is actually 2 distinct canals. So I have given them a little bit of a clean out with these rotary and reciprocation files, and now I'm using this hooked DG endodontic probe here just to remove the vast majority of the gutta-percha. And when you remove the gutta-percha, you can see that the ends here indicate that this is the end of the GP cone. And this indicates that, of course, you've got like the GP out of near the apical end. But once we irrigate and aspirate all of the teeth, we can see that there's still a little bit of GP remaining in the lingual aspect of this tooth. Maybe it's stuck in the isthmus, but it's difficult to see. So I'm just going to use an ultrasonic tip here to try and dislodge it. Again, using an ultrasonic tip, sometimes the GP sort of travels up the tip. I'm using it dry, of course, so I've got a little bit of vision. Sometimes that's an argument to say it might not come out if it's got a little bit of irrigance in there. But I think that this GP is getting stuck because I think there's a lingual shelf here. And what you'll notice is if you do a lot of root canals, if you remove an overhang close to GP that you're trying to remove, this can just be that tiny little catch which is getting stuck on the GP. So in this case, I'm just removing the lingual shelf in this lower right one. Always irrigating, always using ultrasonic activation, especially in the other teeth. And we can see now that the lingual shelf has been removed, and this helped me visualize the GP a little bit more. Again, I'm just using a little bit of ultrasonic here. You see that's kind of dislodged the GP. It's kind of a catch-22, remember, because sometimes it can break up the GP. And what I can see is I think the GP is stuck between the isthmus, between the lingual and the buccal canal. So what I'm going to do is I'm going to try and use a rotary file here. In this case, I'm using a glide path file, kind of down the sort of the join of the isthmus, kind of down the wall of the isthmus, and try and remove some of that GP to no luck, of course, here. And then I'm going to use a high diameter 2007 rotary file here down again the wall of the isthmus. Now I'm not trying to shape out the isthmus, I'm just trying to there's probably about a bit of wedge denting, which is where the GP is getting a little bit stuck. And here I'm thinking to myself, maybe it's gone. And then I have this kind of light bulb moment, and I think to myself, well, maybe the lower left one has also got a lingual canal as well, and I've missed that, because you'll notice that with the anatomy with teeth, contralateral teeth are very, very similar. So I'm just going to use my diamond tipped ultrasonics in this lower left one just to remove the lingual shelf. Again, I'm concerned about heat here, so this is on a very, very low heat. I don't want to be doing this too much because I don't want to cook the periodontal tissues. Also don't want to break the tip, because that'd be a bit of a disaster. But once we remove the lingual shelf of the lower left one, we give it a bit of an irrigant, bit of an ultrasonic, and we have a little bit of an assessment. I think that it's only the lower right one which has got a lingual canal. Now the lower left one looks a little bit like it's like ribbon shaped. So I'm going to move back to the low right one, and we use the 2007 to try and get down the isthmus, but now I'm going to use an even higher diameter file. This is the 35 wave 1 gold, trying to get down that kind of the wedge of dentin, which is what's sticking the GP in there. And then I'm just going to use a little bit of 2007, a little bit of irrigance, a little bit of ultrasonic, a little bit of wave 1 gold, just trying to remove this tiny little piece of GP, but still no luck. It's just very tenacious, that little piece. I suppose an argument to say you could leave it in place, but the issue with that, of course, is it might be infected. Still trying lots of persuasion with all the different techniques. I'm going to move back to my GP remover tool. I've got this kind of, it looks like a DG16 endodontic probe with a very, very small hook on the end, and I'm just trying to dislodge some of that GP. The issue with these GP remover tools is they are incredibly expensive for what they are. So I believe they're about £150 for a tiny little probe with a hook on the end. And the little hook is very, very fragile. So in this case, what I'm trying to do is I'm trying to hook the GP rather than get the hook caught on the dentin, because the dentin will blunt this kind of little hook on the end, and then you have to buy another tool. But I'm suppose I'm removing little tiny pieces of GP from this tooth, but it's not removing the main bulk. So I'm going to change tack here. What I'm going to do is I'm going to get a H file, and I am going to make a bend in the end of this H file. And this the H files are great because they're very, very rigid. So if you make a bend in a H file, it is more likely to keep its bend. It's obviously more likely to fracture also. So this technique isn't for the faint-hearted. And what I'm going to do is I'm going to get the H file, and I'm going to position the hook in the opposite direction to where the GP is. So I'm going to rake this H file down the lingual canal, okay? And then once I get past the GP, I'm going to turn the hook around so it faces the GP, and I'm going to pull the H file upwards, and hopefully that's going to hook out some of the last remaining GP. And what you'll notice here is that we do lots of irrigants, we do lots of ultrasonicking, and then this final sort of irrigant here, we can see that final GP piece has been removed. And that was probably a bit quick for you here, so we'll just do a little bit of a slow-mo, and you can see as we irrigate the canal, you can see that little piece has come away. So this is fantastic. So as you know, I like to have goals for each of my appointments, and the main goal with this appointment was to remove all the GP from the lower right one. I had additional goals, and that was to shape all of the teeth. We've kind of shaped all of the teeth, but we haven't shaped the lower right one completely. But we're getting to the end of the appointment now. I'm happy that we've shaped the canals enough in all of these teeth, so we've got some irrigant down there, and also we can flow some non-setting calcium hydroxide down there. So this is going to start the disinfection process. We're then going to fill each of the canal spaces with PTFE. You can see here now, it looks all nice and neat. And then we're going to fill the teeth with GIC. I prefer GIC over Cavit, mainly because I feel like it creates a chemical bond. It's a bit more robust in this case. And then obviously we're going to check the occlusion, remove the rubber dam, and we're going to get the patient in at a later date to complete the root canal. Appointment 2. What I like to do is I like to recheck all the working lengths. We like to reshape everything again before we obturate. But before we do anything at all, we need to place the rubber dam. We do that multi-isolation technique again, where I'm doing multi-isolation from 4 to 4. I obviously put the rubber dam on, I start to access, and then I think to myself, you know what, I feel like this rubber dam isn't on quite correctly. And in fact, there's quite a large hole here where we can see the upper teeth. And I suppose in a way, this could be fine for a patient, but I am using very, very small instruments, and I think this is quite a large gap here. So what I do need to do is I just need to replace the rubber dam. And of course, I know I've accessed the teeth, but very, very quickly, I ask the patient to stay very, very open, because quickly I'm just going to remove the rubber dam, and I'm just going to adjust the stamped holes further down the sheet. So this obviously creates a better seal, and we can see here this is much better. We're going to then remove the remaining non-setting calcium hydroxide. In this case, I like to use sodium hypochlorite, but I've been told that 17% EDTA probably works even better to remove the sort of caked on sodium hypochlorite. But in my case, I like to use sodium hypochlorite because obviously it's just starting the disinfection process, but also I use ultrasonic activation. So you'll notice that when you're irrigating these teeth with sodium hypochlorite, it removes the big bits, but it starts to run clear. If you just pick up your ultrasonic, start to use this in the canal spaces, this kind of creates that milky effect, and it cleans everything up quite nicely. I'm then ready to just check our working length. The lower left 2 is fine. The lower left 1 is also fine. That's the same. Sometimes you get a different result. It's always good just to check. But actually what I didn't do last time is I didn't check the working length of the lingual or the lower right one. I want to notice here is I actually quite can't get to length on this. I feel like it's maybe a little bit of a ledge. So I just make a very, very small bend at the end with my hand file. And then when we push this to length, I get to the 0 reading. And this is a strong indication that the buccal and the lingual merge at the apical end. And of course, we could take a cone beam CT scan, but I'm quite confident that this is the correct sort of anatomical variation within this tooth. And obviously I'm just stopping the patient from having excess radiation exposure. So we've got the working length in the lingual. We know the working length in the buccal. Just need to make sure you take your time. If you're getting a ledge, don't push it too hard because you're going to make the ledge even worse. And then ready to do the final shaping in the lingual, because remember we didn't shape it last time, and using the 1403 tooth saver file, using it in T mode in this case. These 1403 files can be bent at the end, so it can get past that kind of ledge. So we've got that kind of reciprocation with the T mode. Once we get past the ledge, we then shape it out by pressing the button, and it turns into rotary. And then I like to use these XP-Endo shaper files. These files have got like a curvy length, and they kind of scrape the sides of the tooth. And you don't have to scrape the sides of the tooth, but in this case, I want to try and remove as much of the obturation material as possible, because the teeth aren't circular shaped; they're oval in shape. So this is more likely to remove all of the kind of old obturation material. And I actually do it in the other teeth as well, because I've got the file open. I might as well give it a bit of a scrape. And we're going to do our final shaping with this Wave 1 Gold 31 length files. You can see it's 31. And again, I just like to reshape each canal. As mentioned before, we've got these longer files. It gives us a bit more leeway. Remember, the lower left 2 is 25 in length, and we're always shaping to 24.5 millimeters. And because the stopper is so big, you need that kind of extra length. And also you can see here that because it's not up to the hilt, the head of the motor, the endodontic motor, doesn't get in the way. So it's always about visualizing and being very, very precise in your length control when you're shaping, because you don't want to destroy the apex essentially. We're going to do the shaping in the rest of the canals. The final shaping in the lower right one, as well as the XP-Endo shaper, we're going to use it, the 35 Wave 1 Gold, and then just doing some final shaping in the buccal aspect of the lower right one. We're then ready for our cone fit radiograph. And what you'll notice is I place the cones to length in the lower left 2, I place the cones to length in the lower left 1, and then obviously I'm going to use 2 cones in the lower right one, but these aren't going to be the matched cones that we use with Wave 1 Gold. I'm going to use these maximum diameter cones. They're quite thin, so if you imagine this lower right one's quite small, so if you put 2 big hefty Wave 1 Gold cones, it wouldn't fit. And you can see that I've placed the lingual to length, and I've placed the buccal, but it won't quite go to length. So if I push up the lingual with the pair of tweezers here, you can see now that the buccal goes to length. So that's another strong indication that the 2 canals join, because I've obviously removed the lingual. This has made a little bit of space so the buccal can go to length. So we know that these fit to length kind of at the apical end, and when we take the cone fit radiograph, it looks absolutely fantastic. All the cones are to length. We've got a kind of nice fluted shape here, and we're ready for our final obturation protocol. But first of all, we need to remove all of the GP cones, and we need to disinfect them adequately. So you're just going to dip them into sodium hypochlorite. Make sure that you've got the lingual and the buccal cones of the lower right one in the right way around. We're going to do our final irrigation protocol. Sodium hypochlorite activated. We've got EDTA activated, and the final sodium hypochlorite activated, and then we're going to dry them with paper cones. We're then going to do our obturation protocol. In this case, I'm using one fill as a bioceramic sealer. I'm just going to use these tips to directly inject the bioceramic into the canal space, and then going to use a disinfected ham file. about maybe 2 or 3 millimeters away from the working length to make sure we introduce the bioceramic to the full length of the canal. And I'm going to push these Wave 1 Gold GP cones to length, and they're quite thick, these, so you've got to be careful that they don't block the sealer and it stops you from pushing it down. But if you do it very, very, very slowly, that gives it chance for the bioceramic to flow around. And then same protocol for all the other teeth. What you'll notice here though is once we have obturated all of the teeth, it's actually quite difficult to remove the GP from this lower right one, because the lower right one is very, very narrow, but it's filled with GP. So sometimes if you're using a heated plugger and you're trying to remove the excess, you can actually pull out the GP cone all in one. So in this case, I just remove the excess coronally and then push it down, condense it down, and then what I want to make sure of is that the GP sits below the CEJ, so we don't introduce any risk for further staining in these teeth. And once we've done our final compaction and everything's down, we can see everything looks absolutely beautiful. We've got some nice access cavities here. We can see where all the GP's sort of been condensed down all nicely, and we're ready to do our final restorations with these teeth. I feel like these teeth just need normal composite fillings, so we're just going to use Scotch Bond here just to push down into the access cavities. It kind of pools when we're using this in very, very small teeth, so I'm just going to use some paper points just to wick out the excess bond. We're then obviously going to use our light cure just to light cure all the bond, and then I'm going to use SDR. This is smart dentine replacement within the access cavities. This is a bulk flow. This is fantastic. It flows, but sometimes with these small teeth, little bubbles occur within the access cavity. So I'm just using the DG endodontic probe here just to agitate the SDR and the lower left one to make sure that there's no bubbles and there's no spaces here. And then finally, when we look at the post-op radiograph, it looks great. So everything's to length, everything looks nice. We've got this kind of domed sealer puff in 2 of the teeth. Not something that I always go for, but sometimes it's quite nice to see that there's been sealed all nicely. And overall, fantastic result. Listen, if you like the videos, please like and subscribe. If you've got any comments, you've got any criticisms, you think something should have been done differently, please comment in the section below. It's always about learning this channel. Again, if you want to join the membership program, we've got early access to content, we've got exclusive content, and I will see you in the next video next week. Bye-bye.